Welcome to our presentation on addiction, mental health, and homelessness. We're going to discuss barriers to services as well as engagement and some of the outcomes from our projects. My name is Jane Hamilton. I'm an associate professor at the University of Texas Health Science Center at Houston.
I'm hogging all the mics. Oh my goodness, look at me. I'm a bad co-presenter right off the bat. I'm Eva Thibaudeau-Graczyk. I am the CEO of Temenos Community Development Corporation. We are permanent supportive housing for people with multiple disabilities who are exiting unsheltered homelessness. So that means that we have a lot of people who are coming to us who are active in their substance use, in addiction, and also serious mental illness. I just want to ask a real quick question of the room. How many folks here are working directly in like a recovery or rehab kind of center or setting?
Great.
Okay. How many people work within housing? Okay. How many people wish they had housing? So, yeah, okay, that's what I thought. Thanks. Well, we'll just keep that in mind going forward.
Great, thank you. So I'm very grateful that this presentation has been supported by the Texas Targeted Opioid Response Public through the Texas Health and Human Services Commission. We have no financial disclosures, and now we're going to review our learning objectives. Sorry, can you hear me? Okay, thank you. Can you hear me now? So our first learning objective is to demonstrate increased knowledge on the relationship between addiction, homelessness, and health disparities within this very vulnerable population. Next, we were hoping that y'all will be able to identify best practice interventions to improve treatment engagement and outcomes for persons experiencing homelessness with substance use conditions in particular, and to also describe how a Housing First program in Houston, Texas is improving housing stability and substance use outcomes for the formerly chronically homeless adults. So let's talk a little bit about addiction and homelessness. So on a single night in 2023, this is across the United States, approximately 653,000 people in the US were experiencing homelessness. This is actually a 12% increase, or about 70,000, almost 71,000 more people from 2022 to 2023. So across the US, y'all may have heard of the HUD point in time count. So looking at all the PIT counts across the US, this has been the largest increase in persons who are unhoused since 2007. And 40% of people that are unhoused are actually in unsheltered locations across the US. That's on the streets and abandoned buildings, or in other places not suitable for human habitation. So there's just a real big need, as Eva said, for housing. And we're all trying to figure out how to create more housing opportunities. So when we think about substance use, it's important to consider substance use and homelessness as a bi-directional relationship. And what that means is that substance use is both a cause and a result of homelessness. So many times you'll see substance use actually arising after people lose their housing. So there's often this misconception that most of the people that are unhoused and they're experiencing homelessness are actually substance users. And so this isn't always the case. Oftentimes this could be a reaction to traumatic stress of going through homelessness. And also among the homeless population, as many of y'all I'm sure are aware, substance use is often co-occurring with untreated mental illness. So it's a form of self-medication. So some of the other characteristics that I want to discuss that are related to health disparities is to this recognition that homelessness is often associated with a higher prevalence of mental illness and substance use disorders when you're comparing this population to housed populations. And so what the research has shown is that there's often more severe substance use disorders, more co-occurring mental health problems, and a greater likelihood of recent and past trauma. And further, the incidence of trauma increases for those that have mental health or substance use disorders. And it often persists after placement in permanent supportive housing, which is something that Eva will talk about more. So despite the high rates of problematic substance use among those that are experiencing homelessness, treatment engagement can be very difficult, as I'm sure y'all are aware. And so there's also many unmet healthcare needs that include poor access to and avoidance of or underuse of substance use services. We're really fortunate in Houston because we're increasingly moving towards models where we have co-located clinics within our housing and within our shelters. And so this has been very helpful in increasing access, but it's also important that we're implementing engagement interventions like motivational interviewing, shared decision making, and we'll talk a little bit more about that because there's a lot of distrust and a reluctance to engage with health and social service providers. This can be due to people that are unhoused having prior bad experiences. Some of it is due to their mental illnesses. They may have unhelpful thoughts or beliefs that may make it very difficult for them to engage. So a lot of times within our intervention, we're working with people that are struggling with psychosis, and so we're really trying to address a lot of the thinking. So I think this is, sorry.
I'll just put in one other piece on that. When people are in extreme stress and trauma, when I'm out under bridges talking to people and interacting with people, they really don't want to be hit with, hey, so how's, your substance use dependency going? So many of us, when we're trained, we lead with what our business is. Mm-hmm. And, we're failing, again, to look at the whole person and what they need in front of them at that moment, which I just want to say, as someone who's worked in the homeless response arena for 25 plus years, I would say that's not all that different from me. Mm-hmm. And I've been housed, thankfully, my whole life, mm-hmm. So.
That's a really good point, because I think with our program, just like Eva said, a lot of what we're trying to do is deliver more person-centered care. So we're spending a lot of time training our providers on how to, look at the client's values, see what's important to them, and let that lead the intervention. So we have had a lot of success that we're going to talk about. And then it's also, when we think about people that are homeless, some of the research that I found is that the health risks that are associated with substance use among the people experiencing homelessness are greater than a lot of the disparities that we see related to race, ethnicity, or socioeconomic status. So this is a population that really has a high burden of physical illness along with the substance use and mental illness. So what are some of the best practice strategies for intervening with people experiencing homelessness? Well, the model that we use that's considered a best practice model is that we want to address housing, substance use, mental health conditions, and primary care needs simultaneously to improve health outcomes and prevent relapse. We've had success with this, and to adapt our substance use interventions to local context. So we spend a lot of time collaborating, meeting with partners, thinking about our local service delivery environment and how we can best also leverage what other people have learned. For example, Eva was one of the first people that I met when I started this work 6 years ago, and she was instrumental in helping us figuring out how to engage the population. I remember you used to come to our clinical staff meetings. It was just so helpful.
Yeah, I think it was so I'm a licensed clinical social worker. Actually, as is my esteemed colleague, Dr. Jane Hamilton. But I do not come from the research background. I've always been, in direct practice type of work and management. And so for a researcher from UT to come at me with my programs going and say, oh, hey, we want to come in and take our great ideas and layer them over everything that you're doing and we're going to be fabulous. I maybe didn't have the best reaction right out of the chute.
I don't think I did either.
But, in really talking to each other and working together, we were able to meld our two ways of me coming from homelessness response and very, person-centered, strengths-based, and heavy, heavy, heavy engagement. And we'll talk a little bit more about our housing model that we utilize that is an evidence-based practice and a best practice. But, we rely really heavily on tons and tons of soft engagement. And you can have all of the economists in the world walk in here and tell me that that's not worth anything, but sitting down and having coffee every day across from someone who's smoking a cigarette and never speaks, and on day 267, they finally say, oh, hi, it's worth it. It's worth it because that's when you get that in to start helping them. And when they have that crisis, you guys know, they're more willing to come to you. And so I think what one of our greatest successes is being able to bring the types of interventions that Dr. Jane Hamilton and UT Homes program brought into our type of housing setting and pair those things together in a compatible way that worked for both our clients and residents, our staff, and also their interventions. And we're going to get to results really soon, and that's pretty cool.
I'm really excited. And so some of the things that we tried, that we didn't know how it would work, but we had been reading about shared decision-making. How many people in the audience have heard of shared decision-making? So this is a collaborative process that's used in primary care a lot. And so what it involves is really honoring the patient's values, preferences, and goals for treatment, and to really let that guide how we deliver treatment. And so we do administer a lot of validated assessment measures at baseline, and we tailor treatment, but we're always going back to the client's goals. And I'll talk a little bit more about our cognitive behavioral therapy intervention in a minute, but sorry, I'm having a little bit of trouble with this. But we use what's called a transdiagnostic therapeutic process. So we deliver an evidence-based cognitive behavioral therapy intervention, but we are tailoring it to people with all different types of mental health diagnoses, substance use, and this has been really helpful. So we're really using what's called a cognitive conceptualization diagram through the Beck Institute to really understand like the presenting problems of the patient. So we're not just treating for depression or a particular mental health diagnosis. So in 2018, we were awarded a 5-year, $2.5 million SAMHSA grant. We've just received a second one, so we've had 10 years of total funding to deliver integrated behavioral health treatment and recovery support services for homeless adults with serious mental illness or co-occurring disorders in Houston. Let's see. Okay, oh, there we go. And so our recovery-oriented treatment is very trauma-focused. And we are also working with community health workers through Eva's, your Bread of Life is your sister organization, correct? And
Correct, yes. So we have community health workers who are trained and employed through our sister organization, Bread of Life. And then TxSUS provides supportive services and permanent housing.
Yeah, and so with their community health workers, they're going into the settings, they're helping to make sure that all of our enrolled clients are linked to primary care services, that they've had their housing assessments. We're assessing for all needed benefits and supports, job training, SSI, SSDI. We're really trying to tailor all the supports to the individual because our long-term goal really is housing stability. We are a harm reduction model, so we're focusing on the substance use, but our program does not have sobriety requirements. Now, some of our sites do, not Eva's, but that's something that we're really working on to really also educate our partners about the need for harm reduction, the need for housing first. And so some of our partners include TxSUS, Permanent Supportive Housing, which is Eva's program. We also work with the Open Door Mission in Houston. We work with the Harris Center Hospital to Home Psychiatric Respite Program. That's our local mental health authority in Harris County. We started out at the Beacon Day program. We also work with another PSH program called Pear Grove. And then we also have conducted quite a bit of outreach at the encampments and enrolled people living in the encampments. And at one point during COVID, we had a pilot grant from the American Psychiatric Association to deliver cell phones to people experiencing homelessness in the encampments, to deliver teletherapy during COVID, to collect COVID assessment data. And that was a very successful project that you were a part of. And so these are our approved goals and objectives. So as you can see, I've kind of combined the two grants into one table for our goals. But our goal has been to serve 1,000 unduplicated individuals experiencing homelessness through behavioral health treatment. So everybody in our program does get offered cognitive behavioral therapy, individual session. It's a 12-session intervention. The vast majority have participated in individual therapy. So I think that's even a misconception sometimes, that people that are experiencing homelessness really just need case management, because we've had so much success with individual therapy, and it's sometimes turned into real long-term therapy.
Yeah, one of the things that I want to say to that, though, is that the way that Dr. Hamilton and her team delivered services was extremely flexible. It was extremely resident-centered in that if people felt most comfortable, the therapist would come to them where they were and meet with them there. And what I have found over these years is that if someone wants to go, we refer them out to the mental health authority. Maybe it's a 3-week wait for an assessment or an intake. Then maybe in 6 months you get seen. By then, so many things have happened, and there's no way that they're going to that appointment. It's not even a priority. So having the flexibility and being able to work like this, I can't tell you the people who come to me, people who I never thought would partake in this, and just say, oh my gosh, that was fantastic. Can I get more? So that, I mean, being able to work with a counterpart that can really tailor their program to the needs of your folks has been a key to the success of this.
Thank you so much for pointing that out, because that's a really great point, because all of our services are delivered at community-based locations. We do very little office-based care, and so we're going to shelters, we are going to day programs, we're going to permanent supportive housing, and meeting clients sometimes in group rooms. Well, you know, we don't go into resident rooms very much, but we really are very much adapting to the needs of the clients, like you mentioned. And so what does our patient population look like? Well, this is for our first 508 that we delivered services for. As you can see, a slight majority are over 50. The majority have been male. I actually met someone today from Santa Maria Hostel that we want to form a partnership with, because we do need to enroll more females. So if you're in Houston, we would really like to talk with you if you have females that would like to participate in our program. So these are some of our other demographic.
I just want to throw one thing in there real quickly. When I look at this, as someone who's worked at the system level around data and projections and tracking progress in the Houston area, when you look at our unsheltered population demographic year after year after year, this is our demographic of unsheltered homeless folks. We have a very, very, very low youth and young adult homeless population, unlike some of our sister cities in Houston or in Texas. And we also have we have very small family homelessness because we have almost no family shelter. So so people, they don't have options, so we don't see it, right? If you don't build it, they won't come, I guarantee you. But we are predominantly, the only thing that skews a little different on this one, I would say, is the 41% African American. Typically, we find 60% plus of our demographic is Black African American, compared to about 22% of the general Houston demographic.
So it's a major health disparity, like you're talking about. And then it's, you know, in line with what she's saying, what we're seeing nationally is that the homeless population is an aging population. So back in the early 90s, about 11% of the homeless population was above 50. Now it's a slight majority. So it's something that we're increasingly seeing, because along with that demographic change comes more chronic health problems, you know, more needs in the housing, which I'm sure you know a lot more about than me. And then also just to point out, like about 94% of our patients disclose past traumatic experiences on a clinical assessment, but actually 66% are meeting criteria for a post-traumatic stress disorder diagnosis at admission. And we're gonna talk a little bit about our reductions there. And so, So we implemented this high-fidelity cognitive behavioral therapy intervention in 2018. I went to the Beck Institute in Philadelphia, and I got trained to supervise the intervention. And then our therapists have completed many online, on-demand courses over the years to be able to tailor their intervention. I provided weekly clinical supervision using that cognitive conceptualization diagram that I mentioned. And we use fidelity ratings. So we actually record sessions with the therapist delivering to the patients. And then I'll pull a random sample of about 10% just to make sure that the therapy is on track. And then we provide coaching just to make sure that we don't have therapist drift, because we really do want to see good clinical outcomes. And so our sessions are delivered once to twice weekly, depending on the preferences of the patients. We will do it less, but we do like to provide weekly therapy, at least in the beginning. So what does our treatment retention look like? Well, over the first 5 years of the grant, we saw 42% of our patients completing all 12 CBT sessions, which we feel is great. I mean, we feel like that would mirror any intervention implemented anywhere. And then we delivered about a range, up to 73 therapy sessions per patient if needed.
I was going to say, I'm not sure that I personally or my children have that completion rate of any kind of therapy or, thing that that's really impressive. I think, particularly what it speaks to is the power of the rapport that is built and the value of the intervention to the client. Because again, especially when you look at some of these places, people aren't locked down in these places. They're not required to, you can only stay here or you can only get services if you go see Dr. Hamilton. That's not how it works. And so to have that kind of follow-up, much less completion rate, is pretty outstanding with an extremely unstable and typically unhoused population.
Thank you so much for bringing that up. So we have excellent therapists, and that's been one of the really fortunate things about this program, is a really dedicated team. So I just want to show a couple of outcomes. So every 4 sessions, we administer the PCL5. It's the PTSD checklist for the DSM-5. And so looking at what's called our marginal means, or looking at our mean scores, every 4 sessions, y'all can see the downward trend in our PTSD scores. Starting out with at baseline at 0, the average of the entire sample was meeting criteria for PTSD, and then by the 12th session, we're down to a mean score of 13.8, which we feel is a significant reduction. We're also, sorry. I don't know why I'm having trouble with this, but we are also a recovery-oriented program. So we use a measure called the mental health recovery measure, which actually measures our clients' own perception of their mental health, where they are in their own recovery journey. And it's a validated instrument that y'all can look up. It's free for use. And so with this instrument, we want to see an increase in scores over time, which y'all can see we have that upward trend because we want to see an increase in the client's perception of their own mental health recovery. And so, sorry, it's kind of skipping. So looking at our outcomes analysis, this is a different analysis that we did to really look at predictors, like what predicts a person either staying in treatment or dropping out of treatment. So what we found is that there were certain risk factors. So if a person self-reported transgender status at admission, they're actually 21% less likely to stay in treatment. So that's something that we're really trying to work on, because we really want to identify gaps in who we're delivering services for, and really try to even identify these patients and kind of drill down and change our approach if needed. If a patient had a diagnosis of major depression compared to schizophrenia, they're a little bit more likely to stay in treatment. Interestingly, patients with an alcohol use disorder were more likely to stay in treatment. And then factors such as self-reported control over life, their ability to deal with a crisis, those are actually are more impaired psychological problems. Those are things that made the clients kind of drop out sooner. We're thinking that it may be that clients that perceive they have more control over their lives, or that they can kind of handle it all, don't really see the need for treatment as much, or if they're more severely impaired, they're having a harder time. So we're trying to really look at these subpopulations within our intervention to understand what's driving retention and dropout. We're also finding that quality of life is associated, with longer, it's really highly associated with retention. And so you can kind of look through these factors. Interestingly, tobacco use is another driver of clients dropping out. And we think it's because some of the facilities may be kind of restrictive in allowing tobacco use, so people are choosing to leave their programs and then then they're not able to access treatment as much. So it's something that we really want to take this data to our partners. And then also,
if I can just intervene. So I think it's so fascinating. Kudos to everyone who does not smoke tobacco. That's fantastic. I'm really happy for you. If PCP or heroin is their drug of choice and they want to chain smoke cigarettes, I really don't have a problem with it. And so, for so many people, it helps ease the anxiety. And if that's what you need right now, then I will sit with you in that, and that's okay. And so, unfortunately, sometimes, we have these really lofty ideas, and we read things and we see headlines and we're like, oh my goodness, everything should be green and LEED certified, and we should all optimize our health in every setting. And sometimes it's just not realistic. So looking at data like this and parsing it out in this way and then bringing it back to our partner community is a lot more powerful than me saying, Joe really only opens up when we smoke a cigarette together. So
absolutely, because it's a process. And that's something that we've learned over the last 6 years, is that you can, SAMHSA, for example, our funder, we're supposed to offer tobacco cessation to all of our clients, and we try, but we're not gonna not allow people to participate because they smoke, or we're not gonna really focus on it. We really wanna focus on what's most important to that client. And so I just wanted to quickly talk about, before I finish my part, about preventing burnout and supporting our therapists and resilience. So we provide clinical supervision weekly, as I mentioned, and just recognizing that therapists are working with people who are homeless and using substances, and it's just a really, it's a population that you can really experience some burnout working with sometimes, and we're finding some of the reasons to be that I'm going to explain. Even the therapists, their own perceptions of their own effectiveness and feelings of failure sometimes are kind of driving their burnout. So we're trying to address that. But during our clinical supervision, we cover a range of topics, including addiction. It's something that we work on a lot because we're both clinical social workers, and we may not have received as much training in addiction as like maybe an LCDC has. So we work on it a lot just to make sure that our clinicians know how to intervene effectively, and also addressing issues like compassion fatigue and burnout prevention. We focus on team building. We provide retreats, holiday parties. We've done a lot of breakfasts and lunch at TxSUS. We got a grant from HEB, and we found that to be really effective. And we even have like provider client lunches. And we even did something with our medical school where we brought out medical students, just really building that rapport across all systems.
We also, as part of what we do that we offer for our residents, we'll have people come in and do art classes pretty often. Sometimes we'll do like meditation or like acupressure. And so we always invite all the staff in to partake of it also. It's a way to relax together, which is important. At the end of the day, we're all just humans getting through life.
So it's just been really well received. So like one of the quotes, we collected some quotes from our therapists. So one of them was, I carry that weight. There is a mourning period I need to go through when a patient relapses. I realize that I need to feel the feelings, not avoid the feelings, in order to maintain empathy and caring. Because we are, as I mentioned, we're harm reduction. So we want to, we just want to focus on that encouragement, moving towards recovery, but recognizing that relapses are a part of it. So another therapist quoted, how am I helping this individual when they were actively using? Maybe a referral is better in some cases. Did I give up? When facilitating a group therapy session, it can cause anxiety when a patient is in the group and under the influence. All eyes are on you as the facilitator. Then I realized it wasn't him, it was me with the anxiety. So I thought that was really neat. And then the other therapists in supervision, have a lot of experience. This is one of our fellows. It's comforting to hear their experiences. So I'm gonna turn this over to you. I'm like not doing a good job with it. I'm
scared
sorry.
of it now.
I'm sorry.
I'm watching. I'm like, don't you want to go ahead and do the clicker for me? All right. So who here, does anybody here work in homeless services? It's a very bright light. I apologize. Does anyone here work in homeless services? Show of hands. Like 3, maybe 10. 10, 12 people, okay. Everyone else is specifically more in like recovery, intervention, prevention types of things, nods of heads, okay. All right, well good. Then hopefully this will be somewhat new to many of you. And those of you who are in the homeless response system, I hope that this is how your systems are functioning. Because what we do at TxSUS, and we in the greater Houston continuum of care, which is what we call the system that responds to homelessness in an area, we have really adopted embraced, and drank the Kool-Aid on the evidence-based practices that have emerged since the 80s in the area of homelessness. We used to think, hey, give someone a sandwich and it'll be better. Wait, maybe we need a clothing closet, a job bank, a GED program, a housing place, a substance use program, a this, a that, everything. And, our programs piled up on each other, and we got to a point where in many of our programs, we were saying, okay, these are the criteria for you to get in. And many of them, you had to have 30 to 90 days of sobriety, coming off of the streets, living under bridges, untreated physical, mental, and behavioral, emotional, and spiritual woundedness. I don't know, who could get 30, 60, 90 days of sobriety at that point. And so what some folks did, mostly on the coasts, was go back to the basics and say, hold on a second, we've piled on all of these great big brain thoughts that we have. But what really is causing homelessness? Well, not having a home. So let's try that intervention first. And so this practice came about that's called Housing First. And essentially, and I'm sure there are 12 slides about this, but essentially I'm not a slidey person, I try. But essentially what it does is it says, hey, you, looks like you need housing and you might have some other stuff going on. Would you like to get on a lease and move in somewhere? And at the beginning, they would say, oh, yeah, nice one. What do I have to do? What's the catch? What rules do I have to follow? Who's going to kick me out? Who's going to tell me what time I have to get up, what my curfew is, when I have to pray, what services I have to go to, what time I have to eat, what I have to eat, all of this stuff, what chores I have to do. And we said, no. It's your apartment. You sign a lease and you move in. And then we have some folks around that are just going to help offer you support so that you can stay housed. And so when we approached it that simply, with housing as a healing intervention, and then bringing all of our awesome supports around people to be utilized voluntarily, we really started to see that it's a huge myth that people who are living unsheltered don't want to be housed. They don't say no to housing. They say no to having, this external control over their lives that at that point in time, they're not ready to give up. And I don't necessarily think that it's fair of us to ask them to at a place and time where they have very, very, very little choice and little control over their lives. So once folks get into housing, we then bring all these services, but we operate out of something called harm reduction. How many people here have heard of harm reduction? Okay, so someone tell me, what do you think of when you think of harm reduction? What does it mean?
Accepting people who use drugs regardless of their sobriety.
Very nice. What does that look like? Someone operationalize it for me. What does that look like in your program if you do that? Well,
Are you doing it 5 days a week? Maybe this week we'll do it 3 days, right? Yes. That's harm reduction. Keeping them alive.
That's right. That's right. Very good. Woo, woo. And what else?
Clean supplies.
Yes, clean supplies. How about just access to medication-assisted treatment if you don't have insurance or money? How about that one, right? How many of you live in places that have easy access to medication-assisted treatment like that? Yeah, right? I'm even seeing the Narcan out there. I'm like, oh yeah, grab that up. This is awesome. I'm like, don't even get me started on Suboxone. But so Housing First and harm reduction are the two evidence-based and best practices that we utilize. What we find is that 85% of people stay housed over 1 year. People tend to renew their leases year over year. Substance use does go down. And oftentimes what happens is someone goes from crack to pot. And when we're talking about problems, what we say, how we operationalize oftentimes harm reduction is, hey, when you come in here and you have a lot of people around and you're all smoking crack and you're in and out of your room, it's really disruptive to the community around you, and property management is hearing about it, and now you have a notice to vacate. What do we do about the notice to vacate? And so what that allows them to do is have a conversation about behaviors. They may or may not want to stop smoking crack. Don't do it in your house. Go to someone else's house and jeopardize their housing. So, but seriously, you know, we're about how do you keep your housing? How do you maintain a lease? You know, don't pee where you sleep.
I'm going to show some of your best practices, if that's okay.
Yeah.
So this is, I'm just going to go through all of them if you want to look at
Yeah.
these.
So again, okay. So we do, I let you know what Housing First was. We do not have any barriers to admission. If you can, if we have a housing voucher, if you have to pass the housing authority, then you have to be able to qualify for the voucher. Other than that, we don't do criminal history. We don't do credit check. We don't do anything. We take you as you are. You'll see our residents, again, very much like what I said, for our unsheltered. And for us, we typically see people, not folks who are coming from emergency shelters, but we typically are housing folks, because we're so low barrier, who are coming directly off the streets. And
No, so we mentioned these already. So since we want to leave time for question and answers, do you think that we could just quickly talk about the nutrition project? Because it's only 2 slides.
yeah, so I'm going to let you talk about real quickly after I do a little intro about the nutrition program. But one of the things that we know when people get housed in Texas, you don't necessarily get SNAP food benefits. Everybody here is nodding, right? Like, we all know this horrible truth. And so what we have is we've moved people into housing, but they still have tons and tons of food insecurity. We've now coined a word for something called hangry. I get it. I think we all get it. Fed people are happier people. People who have some nutrition utilize fewer substances. Their health and wellness is better. Their mental health is better. And so we were able to work, again, with UT and with Dr. Jane and with our sister organization at Bread of Life to implement a nutrition program for our residents.
Yeah, and so one of the things that we learned, we read a study out of California that found that about 64% of people in permanent supportive housing in California were food insecure. So we got a grant from Houston Methodist, and we measured that using the USDA Food Security Survey, and we found similar rates. So what we did is we created a multi-level intervention that we've published, and our goal was to not only increase access to healthy foods and SNAP benefits and WIC benefits, but we also had nutrition education classes provided by the School of Public Health. We had weekly cooking classes. We had nutrition games that we developed for the community. We had grocery store field trips. One of the things that came out of it is that many people that were exiting homelessness had not been to the grocery store or even in a car in years. And so we were managing a lot of anxiety around going to the grocery store, reading nutrition labels. You know, we built a community garden. We really worked on social connectedness, and we had a lot of community meals. So these are some pictures from our project. And so I just wanted to quickly touch on that. We can ask this multiple choice question at the end, but first we wanted to go ahead and open up the session for some questions, if y'all have any.
We do have some questions.
Okay,
If you want to answer this poll, it is in Whova, so you can answer that at any time. I have a question online, and then I'll come around for anybody who's got questions here.
Perfect.
Let's see. The first question, how can we encourage our government offices to see homelessness as a symptom to a greater problem?
So I've spent a lot of time doing national advocacy work, education work, and meeting with different government officials. They tend to see it. I mean, what I always lead with is that homelessness is the dumping ground and the failure of all the other systems, right? I mean, homelessness isn't really its own category. It's like failure of education, the penal system, of employment, vocation, racism, institutionalization, mental health, all that stuff, right? And we get it. And so, yes, there is a specific department that gives money to this, but to date, elected officials and government officials, while they understand it, they've not made the types of moves to actually carve out money for housing within education, money for housing within criminal justice, money for housing within health and human services.
That's a good point.
We've made a lot a lot of progress, I think, in the health and human services realm, with more and more managed care providers starting to understand and really getting that link between emergency visits and repeated emergency visits and lack of housing. And so in some places, you know, because there are cost savings and cost benefits for the insurance companies and the managed care companies, they are putting up money and partnering on housing. It hasn't happened here yet because we're not a Medicaid expansion state.
Yes, and so that's a really good point. And thank y'all. It's such a great question because I think one of the things I started out looking at psychiatric rehospitalization and looking at predictors, and what I found is that homelessness is like really one of the strongest predictors of rehospitalization. So that was really the data we used to get our grant. And so really, I think one of the ways that we need to think about convincing, you know, whoever, governments, foundations, to look at homelessness and to fund it more is to really collect good data. So that's why we collect a lot of data at multiple time points throughout our project. And that's another kind of misconception that I think we've addressed is that, yes, actually, our clients like to complete assessments sometimes because these are questions people have not asked of them. You know, what are your trauma symptoms like? What is your substance use like? So I would just say that the more we can collect data, especially using validated instruments, the better. And then just using that to kind of base our advocacy on. Is that good?
Okay, ooh. Yeah, raise your hand, here we go.
Hi, my name is Chanel, and I work here for Communities for Recovery. We do peer support, but we work with a lot of unhoused. And one of the things that I'm finding that we have a challenge, because I do outreach as well. I work on 2 different grants. But the thing that I'm finding is so challenging and frustrating is Austin is growing, so they are throwing up apartments everywhere, and they are making like a certain percent of them to be income-based, and they have the ones where they're giving out the vouchers, but you're making them income-based, and then you're doing background checks. So now people who have vouchers or may have a job, now they can't get the housing that's of income-based because they have a background. So now they're forced to move into the environments they don't want to move in that will accept their background, that is flooded with the things such as the drugs and other things going on in those type of properties. So what can we do more as a people, or where do we go, or where do I go? Who do I write to? Because like it's really ridiculous. Rent is super, super unbelievably high here, even in the places that are supposed to be affordable. Like it's ridiculous. So what do we do? How would we advocate? Because I'm a person who has a background, and it was very challenging for me to find a place, and I'm in recovery. So as a person that is like that, one of the biggest fears is not being able to take care of my kid.
Yeah.
I don't want to be homeless, but I don't want to move into an area where they have lots of drug activity either. So what do I do?
So I think, thank you for sharing that, first of all. Thank you very much. And I think what you speak to is, I was looking around, lots of nodding, a whole lot of empathy and understanding, I think, frustration at that very thing. There are 2 things. One, of course, and this goes even, I think, before the background check piece, is accepting your rental subsidy. Like, what is your income source for rental? If it's a voucher, in Texas, you can just say, I don't want to play with you, go away. So number 1, you're limited by who will even take a voucher. And then it's the background check piece. So just a quick, if this helps anyone, your local public housing authority has a lot of ability to waive some rules and requirements on appeal. And in our area, our local housing authority, the Houston Housing Authority, they have a special categorization and specific rules for the category that they call, homeless by the HUD definition. And so if somebody is rejected because of a background, but the property will still take them, we are able to do a waiver. So there are often things that you can do. Property owners, they can also, if you advocate, one-on-one, they can make a decision to take someone in. And what I want to say is that you are talking to us about a systemic problem. We are all feeling the pain because it's highly individualized and we feel it all the time, but that is a systemic problem that needs to be addressed at a huge level.
It's such an important issue. I just want to say one other thing. So when we got our original grant, we partnered with Beacon Law in Houston. So I think the more that we can bring in legal aid clinics and legal partners to help us guide through this, to really go through this process, which is very complex, like you're talking about, the better.
And then we'll alternate questions online. The next one here is, do you have any ideas to help increase attendance to programs that aim to help the homeless population?
I do. I mean, I'm going to hear your thoughts too. So we have not had an issue with attendance or an engagement, which was a real surprise to us. So I think that it comes down to as you said earlier, the provider-client relationship. And so we spend a lot of time like interviewing and finding the right providers, and then also really monitoring to see, how is the care delivered? How are people engaged? What could we do different? And just really trying to have empathy and listening. We work a lot on health communication, shared decision-making, motivational interviewing, and I feel like it makes a difference.
I think what this project has done, again, is it's taken its groups and services to where people already are. And so that in and of itself is unique. So I don't want that to be lost sight of. If anything you can do where people are. The other thing is people call and volunteer all the time. They want to do a group on finance and budgeting. And I say, I could use some finance and budgeting classes, but I don't want to go because it sounds really boring. Can you make it a little bit more interesting, right? Can you make it enticing? And just because people are experiencing homelessness doesn't mean that they don't want that as well.
That's a really good point, because with our intervention, we provide a lot of art therapy. So we spend grant money on art supplies for our therapy. On our homework, we've also adapted it a lot for the population. So we read every single intervention activity in a manual, and we will rewrite it. We look at the literacy level, we look at the language, because we want to avoid language that a person that's experiencing homelessness, we don't want to use things or even thinking about what they can afford, we really want to make it to where it's completely relatable to them, if that makes sense.
Hey, my name is JJ Ramirez. I'm an organizer at Vocal Texas. We organize people who are impacted by and against to end the drug war, mass incarceration, HIV and AIDS, and homelessness. And I'm directly impacted in all those except for living positively. So I have a few points, and then I do have a poignant question. So some things that you can do is organize. Bring your people with you, do political education, let people who are experiencing homelessness, people who used to use drugs, speak for themselves. You don't necessarily have to advocate. You can let them. We do it every day. I really appreciate y'all going to the people, because what a lot of people overlook is transportation. Here in Austin, we fought and we won free transportation for people who are experiencing homelessness by organizing against the local transportation ordinance, right? And then another thing is I know this is a big recovery place, and I really appreciate to respect people in long-term recovery, but when you're failing people because they're using drugs, if you just had accepted the fact that they use drugs to begin with, and if they go to recovery, you're just helping them along the way, maybe you won't feel so let down that person chooses to use drugs again. My poignant question is in Texas, right, and you guys do permanent supportive housing, which is the best, right? The rapid rehousing, temporary voucher is trash. How are sweeps in the state legislature affecting Houston on being homeless? Being homeless is illegal. You cannot camp. They will throw everything away, your ID, your social security, birth certificate. How is that impacting your work in Houston?
So all that I have to say about criminalizing homelessness is that all it does is muck up our stuff. When I talk to council members, when I talk to the mayor, whatever, we're saying, look, you can write, and honestly, our Houston Police Department goes in front of civic associations and neighborhood associations, and it's it's not worth our time to write a ticket against an ordinance for laying or sitting on the darn sidewalk for someone who has no money and isn't going to pay it. And then we're going to have to give them a warrant, and then they're going to come and sit it out, and then. And so, I would just say as a blanket statement, criminalizing it may pacify a few constituents, but it does absolutely nothing to help solve or end the problem.
In your outreach, are you having like really difficult trouble tracking people because of the sweeps? Like in Houston, how is it like affecting?
Oh, the sweeps. So we do not do sweeps in Houston. We do encampment. So we do encampment closures, and I have not. So there are unintended consequences to everything you do, right? And you don't know when you're going in. So for a long time, we thought, hey, let's go ahead and house whole encampments together if we can. Like let's go in. We're not going to kick anyone out because if you tell people to leave, then you can't find them and get them housed, right? Hello. So we would get everyone to know know everyone, figure out where they could go, house them together, house them as couples, house them separately, whatever, and then we would fence in kind of that area so that another encampment didn't happen. We housed a lot of people, and we're still doing that. One of the unintended consequences is that when you fence off a whole lot of gathering places where people can be mostly unnoticed, they end up being a lot more visible. And so then you get more complaints from communities saying, why are there so many people homeless? And we're like, no, we house them. But I know that Austin is particularly experiencing that with the different freeway closures, and things are pretty ugly here. And in other places in Texas, they really truly are doing sweeps. And a sweep is just coming in, telling people to leave and to move or you're going to ticket them.
Yes, and that's, like you're pointing out, that's very ineffective. And so Houston has really led the nation with our model of housing the people that are experiencing homelessness. And I believe I read recently, is it like 115 encampments we've decommissioned in like the last few years, and using the model that you talked about, going in, building trust, using our nonprofit agencies, getting to know the people there, and then finding housing for getting the housing ready first. And that's
I don't want to, and I don't want to be too kumbaya about it. It's homelessness is dynamic.
That's a good point.
Every time we house someone, systems are failing and someone else is falling into it. And so, it's not a one and done kind of thing. It's ongoing. And until we as a collective society make some really different ethical and value choices, this is the work that is going to keep being in front of us. What we want to do is to make it as brief as possible and to get people housed as quickly as possible.
You're making a really good point. I just want to give you a shout out too. So when I first met Eva in 2018, 2019, we were at the Beacon and we were serving a large population of unsheltered people who were coming into this day program. And I, came to her, I'm like, one of our outcomes is housing, and I was really stressed about it because I was kind of learning about the area. But fortunately, a lot of funding, especially through COVID, was really made available for housing. And y'all took about a third of our enrolled patients. I would say about 100 of them have been housed at your
TxSUS.
programs. And so that was also a really neat thing because we were able to re-engage them and deliver services again to really improve housing stability. So I do feel like what we're doing is successful in a lot of levels. So.
I'm Tanya. I'm out of Houston as well with Texas Clinic Healthcare System. We're the largest MAT program in the Houston area. We have multiple clients that we serve a lot of homeless people in our MAT program. And one of the consequences of the housing, believe it or not, is when they're unhoused, they're able to stay local to our facility. They may get housing, which is fantastic, but it's on the southwest side of Houston. Now transportation, which is always a barrier, becomes more of a barrier. So they find themselves leaving this housing and will sleep in the closest bridge on Irvington so that they are close to our facilities so that they're able to get their medications. When we talk about funding, I heard somebody told me today that Austin has this thing where you can get like a 2-year bus pass. What are we doing in Houston? Houston is twice the size of Austin, with more people. We're doing great housing, but we're housing them away from the services that they've become accustomed to that they got when they were homeless.
10,000%.
So can we get a bus pass? Can we get a Metro pass? Can we get an Uber pass?
Yeah,
Can we get something?
Yeah, every grant that I write, we easily ask for $40,000 in Metro passes annually. Every single case managed housing program has a case manager assigned to it. And if they did not get transportation is we ride in Uber and Lyft now, you know, and so when we're leasing a small van, you know, all of these things. So I think that there's a disconnect. Transportation that's a lot more tailored than get there should be available. So
Absolutely. And I was going to just one other point with that. So we have a lot of these issues as well in our program. And so we're also working with our community health workers to help them, you know, to make sure that they understand that people need help even getting on a metro and making it somewhere, because Houston's such a big city. So it's even if you have the bus passes, it doesn't mean that our clients are going to like be able to like navigate.
And I mean, that's written into our job descriptions, is that you must be willing and able to take public transportation wherever your client needs to go in order to help them figure out how to get to where they're going.
All right, y'all, we've got time for one more question. You've had your hand up the longest. So I'm gonna go here. You can put your questions in the Whova chat, or we can talk one-on-one afterwards, but our last question for the day.
My name is Mandy Schumann, and I'm a community health worker in Abilene, Texas. I wanted to know how to get the buy-in for the continuity of care within organizational collaborations. Like, how are you doing that, and how to do it well? And so that we can, when we house them 24 months later or 12 months later, we're not continuing to see them in the same situations.
So I'm sure Jane has a lot to say too, but collaboration is so difficult. You know, it's easy to send a referral out into the universe and it doesn't go anywhere. A collaboration is intentional. It takes time and it takes someone to tend to it. In our area, we have a lead agency that is tasked with and actually gets administrative money from Housing and Urban Development to help keep all of these pieces working together. I would go to your local continuum of care and see how they can strengthen that.
That's a great point, because we work, so our continuum of care in Houston is called The Way Home. It's run by the Coalition for Homeless Houston, and they're really the ones that we're deferring to a lot to even help us arrange stakeholder meetings, to reach out to other clients. And they also run our HMIS, our Homeless Management Information System. So we make all of our referrals through the HMIS system.
Yeah, and I can stay for a little bit after. I'm not sure if Jane can or not, but we just really thank all of you so much for being here and for the work that you do every day, and thank you for taking time out to learn more.
Yeah, thank you. We're honored to be here and that y'all are here. Thank you. We'll stay.
Okay, and if we could just post the answer to the question, just move forward one slide. All right, thanks everybody.